I would like to invite the discussants and Dr. Van Assen, Dr. Walstra, is he here? Okay. And Dr. Jaruzelski. And Dr. Stillman and I will entertain you for a few more minutes. We prepared a couple of poll questions. Okay, do you routinely report calcium on your lung cancer screening patients? Yes or no? Please scan the QR code and quick answer. Yay. Oh, here we go. I count 700 of you in the audience, so 17 votes is not enough. Come on, vote. Okay, so the majority says yes. The 2/3, 3/4 actually, report coronary artery calcium. Let's go to the next question, please. If you report coronary artery calcium on your lung cancer screening patients, do you visually grade it, like mild, moderate, severe, or none, or report an Agatston score? A few more seconds. It seems to be almost a 50-50 here, although visually is probably a slight majority. Okay, next question, please. Do you provide a distribution of calcium in the left main, in the LAD, in the circumflex, or you don't bother? Yes or no? Just a simple yes or no. And again, almost a 50-50, in actually slight favor of no. You don't bother to say where calcium is accumulated. All right, in the interest of time, let's go to the next question. Based on the severity of calcification, do you recommend any additional imaging? Do you recommend any additional imaging in your report? Okay, that's unusual for radiologists because you always say consider, but not in this case, eh? What is the percentage of liars among you today? Answer that question. Okay, never mind. Next question, please. Next polling question. Do you recommend consideration of treatment with statins based on the presence of calcium? Hmm, 50-50 again. Maybe not. Okay, the majority would say no. You expect the referring physician to do something about it, probably, correct? I think there's one last question. Would you like to have an AI-generated calcium score? I guess this is a quantification calcium score added to the final lung cancer screening report, like an Agatston score. Would you like an Agatston score added automatically by AI to your report? Ooh, majority. There's no debate here. Okay. Very good. Thank you for answering all those questions unreliably. I'm just kidding. Let's repeat them again. Let's do the reproducibility test. No, I'm just kidding. Okay, now to the panel. Let me ask you the general question. Actually, let me address my own colleague there, the only other cardiologist in the audience, Dr. Jaruzelski. Or Jaruzelski. Jaruzelski or Jaruzelski?
Jaruzelski.
Jaruzelski.
More optimal.
What did you perceive in today's session, or maybe even yesterday, that you would do different in your practice, if you even did perceive anything different from what you typically do?
Actually, I'm really impressed by these presentations because I'm interventional cardiologist, so I work in the cath lab with a modest, let's say, experience in outpatient clinics. What we see in the cath lab, our patients are not taking drugs, and therefore, when we look at the coronary angiogram, we see lots of problems. Especially the first thing is that the patients are coming for coronary angiography with no indication, and everything starts, of course, in the outpatient clinic. We use SCORE. We have SCORE 2 that should be used. Of course, it is based on risk factors. But on the other hand, we all know also that it's not very optimal nowadays, because we have now CAC SCORE on board, which is actually not a new kid on the block. It's rather a tool that we should use in a daily practice. So if it's a possibility that cardiologists have to send the patients for CAC SCORE or even CTA, which is of course much better, it should be done, because we all know, and it's already in the guidelines, that when we have a patient with a low or moderate risk, for instance, with CAC, the reclassification goes really, the reclassification is in lots of the patients. We have zero effect, which was mentioned today many times, and we know that the patient goes from moderate to low risk. But on the other hand, when we have CAC SCORE, for instance, of 100 and more, we should start statin therapy, and this is based on guidelines partially, but also based on our clinical practice. However, at the end, the situation is like the patients are not taking drugs, and at the end we have the situation that we do coronary angiogram of the patient who comes to the cath lab for the second time, for instance, and this is because he's not taking the drug. So the problem is quite big, I would say, because one thing is that our tools are not optimal, and we should use additional tools like CTA scans before the patient comes to the cath lab. First thing is that the patient should be adherent to the therapy, because there are lots of problems with non-adherence in our daily practice. So one thing is what we were discussing today. Lots of research and nice studies were presented. On the other hand, it's very important that the patient has good, let's say, patient path, because at the end, the patient, when comes to the cardiologist, it's important he has echo, for instance, because left atrial dimension will give us also very important information before the patient has, for instance, AF.
Let me ask Anna Walstra. You're a radiologist, right, Anna?
No, I'm a technical physician.
Oh,
sorry. No, I'm a technical physician, and I'm doing my PhD with iDNA and Erasmus MC on the For the Long Run study.
okay. Do you do reporting, or do you help with reporting?
Yes, we do the automatic calcium score for the long run. So we have the AI-based method.
But I actually was about to ask you a different question. Do you do reporting of chamber volumes or chamber size?
No, not at the moment.
You
but
don't.
I think the AI system
What
we use...
about Marley?
does
Do you do that in your reports?
So we don't.
I think it should.
Okay. We don't, but research-wise, we've been starting to do it on calcium scores, where we measure chamber volumes. We even started doing it on our lung cancer screening patients, but we have issues with the timing, because it's a chest and it's non-gated. You get systolic, diastolic differences that we struggle with.
Absolutely.
But we have been doing it on our calcium scores for research for heart failure prediction and AF prediction.
I see. Very good.
With AI.
With AI.
Nobody wants to do that manually.
Who among you looks for evidence of liver steatosis on your reports, on the dome of the liver? Anybody looks for presence of low attenuation findings? No, nobody looks at it. Are you interested? Would you be interested in
Yes, I mean,
finding out?
I'm very jealous actually because nowadays the situation is like I'm a fan of CTA and we have a great team in our radiology department, people who are specialized not only in radiology but also cardiology, for instance, and now we are getting reports with information about if the patient has high-risk plaque or not. And it's very important, in my opinion, nowadays, because many times we have the situation like for whom we do CTA, for the patient that we want to rule out CAD. And when there is a situation like we do it, and at the end the patient is young and has a plaque of 30, 40, percent of stenosis, but is a high-risk plaque, I mean, has a characteristics of a high-risk plaque, we are quite aggressive, honestly, with which is borderline. I mean, not everything is described in guidelines, but we have a lot of studies showing that when the patient has unstable plaque, it's very dangerous. We have now a PREVENT study, which was of, it's my field. MI patients who were coming to the cath lab and were stented for not only culprit lesions, but also non-culprit lesions, which were not significant. And at the end, the MACE risk over a long-term follow-up was down to 0.3. Which means we all know that that coronary artery disease is a chronic inflammatory process. So basically, never when we have the patient with MI, he comes to the cath lab. We do culprit lesion, but at the end, non-culprit lesions are on board in 40 to 80% of the patients. This is information from autopsy studies. So at the end, we know that we should start aggressive therapies with dual antiplatelet therapy and of course statins. But on the other hand, we are not limiting the MACE risk, unfortunately, to 0. It's like 3-4% over a year. So if the patient is adherent to the therapy. So basically, the thing is that we should really look at the patient generally, and when we have a high-risk plaque on board, it has to influence our even therapy, not only lifestyle modification.
Doctor,
do you think
the stenosis can be like 20-30%, and the plaque is more dangerous as compared to the plaque which is with stenosis of 70, sorry, which is significant but is stable.
Yeah. Yes.
But I do think we report high-risk plaque features. I know Dr. Stillman probably has more experience with this than me, but we do report high-risk plaque features on all CTAs if we do them.
Now, the question was more about the cardiometabolic disorders that we are facing. I think that Dr. Stoyanovsky did a great job in introducing that. But let me challenge you on one concept, and I would like Dr. Stillman maybe to take up this particular question. You talked about the fat fraction. You mentioned the FAI, or the fat attenuation index, or the pericoronary inflammation that you mentioned earlier, or what we believe or have been sold that is inflammation around the coronary arteries. Dr. Stillman, you did some work on that particular topic, and you came up with an interesting observation that there are many factors that can influence FAI measurement. What did you conclude?
Well, there's the pericoronary fat, and then there's the epicardial fat, and they're different. And we did a nice study, I thought, in the epicardial fat showing that even the season of the year influences the quality of the epicardial adipose tissue. So it's complicated, and that's I don't think has really been taken into consideration in any of the studies I've seen. They've all been pooled over the course of the year. The pericoronary fat, I don't know if it has a seasonal variation or not. I do think it does reflect coronary inflammation. And so it's interesting, and it's clearly a risk factor in itself, an independent risk factor. So,
There's actually a publication from another group, from an Asian group, that showed that there are multiple factors affecting the pericoronary attenuation, not just the epicardial attenuation, and among other factors, season, statin use, smoking, which is similar to what you demonstrated. So, Zadranska,
Right.
what do you say to that? Have you looked at changes in your measurements with changes in seasons and treatment?
So what I actually measured was the epicardial adipose tissue, and I did tissue analysis and looked at ceramides as one of the culprits, and there were other lipids that were culprit in the chronic inflammation. Chari's group, that's why I went to Oxford. So Chari's group at Oxford, they actually looked at the pericoronary fat, and for them, it was very easy to run all this or recruit patients, because in the UK, they're not IRB restricted. They basically took tissue specimens from all patients that were undergoing CABG. So they found very similar things, and they've published that about the ceramides that were linked to the inflammation, and their population was actually very big. So I do think that there is the coronary inflammation, and they were able to detect it. And I don't know how other tools are different, to be honest. I only know about their tool because I have collaborated with them. And I do feel that the chronic inflammation is the culprit from the coronary artery disease. And definitely those two depots can be very different, as you mentioned, only because the cells are very different. It's not only there's one cell, there's mixture of multiple cells.
What I'm trying to aim, though, for here
Okay.
is not so much to dispute that FAI or the fat fraction that you measure on MRI may be markers of risk. I'm just claiming, or maybe making a statement here, that we shouldn't be relying too heavily on one measurement one time, and that one measurement may be affected by multiple factors.
Oh, that is absolutely true. That is
Right.
absolutely true. But however, what I wanted to tell you is that with the Chari's group and also with my group, and when we're talking about the AFib and the volume, it's very important to use all the covariates when you're using any to analyze it. You want to make sure you adjust for other factors. So Chari's groups, they adjusted for all other factors. And that's why I said that the inflammation and the number stood out among all these other factors to predict outcomes. And you're absolutely right. And I did the same thing in most of my studies. Is basically when I showed that Kaplan-Meier curve in AFib population, I adjusted it for volume, left atrial volume, left atrial size. I also adjusted for sex. I adjusted for BMI, BSA, and also other CVD risk factors. So all of them came into account, and the epicardial adipose tissue in my particular study was an independent predictor. You're absolutely right, but you have to adjust for other covariables.
Can I?
Yes,
Yeah, because I think it's great, because I know TERS very well, and I know their algorithm, and it's great that you correct for all those confounders. What I do want to emphasize is what Professor I-ELCAP also said about the calcium score, is that your technical considerations of your scan, especially for pericoronary, because we show very, very small margins between patients. And a lot of them is different KV levels, different scan protocol, different scanners. So there is a lot of protocol variation that if you look at a population measure, it shows really good results. If you look at a per patient measure, you don't only have to correct for all of your biological covariates, but there's a lot of technical covariates that go into place, and I think it's going to be even more enhanced with the new photon counting systems. So there's a lot, I think, of factors that you need to correct for it, make it really, really hard to use it on a per patient basis, because there's so much that goes into it.
So I just want to come back to that particular comment, is because they all have used the same scanner. Even with my study, we all use same scanner, and the Oxford study, they've used one scanner. So it was all done on one scanner. So all parameters, same parameters for every single patient. So that's why they did not correct that in their analysis.
Their algorithm corrects for it. So I know that their algorithm corrects for a lot of the protocol, but it does mean that if you do it at other hospitals with other
yeah,
scanners, right?
absolutely. Yeah,
If you want to
absolutely.
use it on a per patient basis, there's so much work there because of all of these technical parameters. You cannot compare scanners because you get different values for it. And that, I think, makes it really, really tricky.
Yeah, that is absolutely true. If you want to translate to another institution, you're absolutely right.
So Anna, you're using artificial intelligence to do calcium scoring, reporting. How do you trust it?
Sorry?
Why do you trust it? How do you trust it? Should it be trusted?
The calcium score.
No, the artificial intelligence.
Oh. Well, for the calcium score, it's always important to know the model you're using, what it is trained on. If it's trained on data that's similar to the CT protocol population that you are also doing. So it's important to validate it, of course. So to know, does it correlate well with the manual expert calcium score? And yeah, this is critical before you do implementation, and also to know when you do longitudinal comparisons if there are no changes in the CT protocol. So you know the data that goes in the algorithm, and you know then also if you can trust the outcome that you are getting.
Are you working on Rubinska?
No, for the long run, but it's based
Are
on
you
a
using
similar
AI
point.
for Rubinska, Matisse?
Yeah.
You mean for AI? To manual performance. I neglected it. No, just kidding. So is Rubinska done by AI or manually, the calcium reporting?
AI.
AI.
Yeah, we did it completely with AI.
Okay.
After the validation, of course.
Okay.
So the big advantage is that you have a complete standardized methodology. And if you can prove that it is comparable with very dedicated analysis of radiologists, what you do in a research setting, and it's not even comparable, it's almost equal, then if you do it on a daily large volume basis, you get far better reliable standardized outcomes than you can ever have with a bunch of radiologists that do it in daily work with decreasing performance during the day. So yeah, it's a no-brainer.
So we have only a couple of minutes. Any urgent question from the audience, maybe to the panel or to the presenters? Otherwise, it is my pleasure to close this session. Thank you for your participation. Thank you for the contributions by the panelists.